Welcome to Nexus Medical Media. In this video, we are going to talk about gout, pathophysiology, and management. Right, so gout, what is this? This is a joint pain that occurs as a result of accumulation of uric acid in joints. Right, where does this uric acid come from? You know, there are nucleic acids like DNA and RNA. These nucleic acids have basic components called nucleotides, and a nucleotide has a sugar, a nitrogenous base, and a phosphate. Nitrogenous bases, there are two groups: purines, which are big, and pyrimidines, small. Pyrimidines include thiamine, uracil, cytosine, and the purines are adenine and guanine. These are the main ones. So as they degrade, they give hypoxanthine and xanthine, right? And these pathways, as you can see, are mediated by the enzyme xanthine oxidase, right, to give uric acid. And uric acid is converted to allantoin by urate oxidase, right? These are some of the enzymes which catalyze or mediate different pathways. Here we're not going to focus on this, is beyond the scope of this presentation, but I just want you to focus on this pathway: hypoxanthine, xanthine, uric acid, and allantoin. All right, so gout can be classified into two groups: primary gout and secondary gout. Primary is usually genetic, occurs as a result of defect in enzymes. The enzymes in the previous slide, you see there's phosphoribosylpyrophosphate pyrophosphate synthetase, phosphoribosylpyrophosphate pyrophosphate, aminotransferase, it should be aminotransferase. This one is hypoxanthine guanine phosphoribosyltransferase. Right, so if there is any defect in these enzymes, the person can have the primary gout. Right, as I said, this is an imbalance between uric acid synthesis and its excretion. So secondary causes include things that increase synthesis of uric acid and things or processes that decrease the excretion, right? So what increases uric acid? Increase the dietary intake, meats, red meat, beef, increase the nucleic acid turnover, various cancers like leukemia, polycythemia, starvation. Von Gieges disease is a glycogen storage disease. What decreases uric acid excretion? Renal insufficiency, lactic acidosis, diabetes mellitus. Okay, let's look at the pathophysiology. So as I said, purines are metabolized to uric acid via hypoxanthine and xanthine. These two intermediates are water soluble and they are easily eliminated by the kidneys. But uric acid is less soluble and it can just be eliminated adequately in persons with healthy metabolism. Okay, my tongue. Okay, so gout results if there is an imbalance between the amount of uric acid produced and the total quantity of uric acid excreted. And gout is characterized by increased levels of urate in blood, right? It's called hyperuricemia. Urate crystals precipitate in parts of the body that provide poor condition for urate solubility, such as the synovial fluid, and where the temperature is lower than normal body temperature. This is what provokes gout attack. The base of the big toe is affected more often by this gout. Like other crystals, urate crystals provide a strong stimulus for neutrophils and macrophages. The neutrophils are attracted and phagocytose these indigestible material, right? So they are attracted as a process of chemotaxis. In the process, neutrophils will release pro-inflammatory cytokines. Macrophages also phagocytose these crystals, and they are injured in the process, and they will liberate lysosomal enzymes that promote inflammation and attack the tissue. As a result, an acute and a very painful gout attack may develop. Treatment of gout. Right, so treatment is actually twofold. Firstly, there is treatment of acute attack and treatment of chronic. This is a lowering of hyperuricemia, chronic lowering of hyperuricemia. The acute attack demands prompt action to relieve the patient from their painful state. Chronic lowering of hyperuricemia, there are 3 steps. First one is appropriate diet, right? So foods high in purines such as offals must be avoided. Purines are found in cell nuclei, so eggs and dairy products may be consumed freely. The second attempt is use of drugs that are called uricosuric, for example, allopurinol, right? So uricosuric agents inhibit the xanthine oxidase, right? So xanthine oxidase, remember, it catalyzes the uric acid production. Next is uricosuric medications. Uricosuric medications, right? So the medications include probenecid and benzbromaron. Wow. Right, so these drugs, they promote renal excretion of uric acid. Right, so let's divide this management of gout into 2: acute attack and chronic gout. Right, let's start with chronic gout. So these drugs are mainly like preventative. They do not work in acute attacks. The first one is allopurinol. Right, so allopurinol is a competitive inhibitor of xanthine oxidase, and it leads to decreased conversion of hypoxanthine and xanthine to urate or uric acid. This is the dangerous component, right? Allopurinol is also used in lymphoma and leukemia to prevent tumor lysis, which is associated with urate nephropathy. Allopurinol also increases the concentration of xanthine oxidase active metabolites, azathioprine and 6-mecaptopurinol. I hope I got it correctly. Right. The next drug is pegloticase. Pegloticase. Right. So this is a recombinant uricase catalyzing uric acid to allantoin, a more water-soluble product. The next drug is febuxostat. Febuxostat, right? So it inhibits xanthine oxidase. So think of it as a febuxostat. It makes xanthine oxidase static. The next drug is probenecid. Probenecid inhibits reabsorption of uric acid in the proximal convoluted tubule, right? As you can see here, it also inhibits a secretion of penicillin. It can precipitate uric acid calculi, right? So these are the downsides, like inhibition of penicillin excretion, and it can precipitate uric acid calculi, the stones. Right, so to remember these drugs, you can use the mnemonic: all painful flares are preventable. All painful flares are preventable for allopurinol, pegloticase, febuxostat, probenecid. Next, let's look at acute gout drugs. Right, so these drugs, 3 groups: nonsteroidal anti-inflammatory drugs, NSAIDs. Right, so we can use any NSAID. like indomethacin or diclofenac. You may use a salicylase, that's aspirin, but use it with caution because it may decrease uric acid excretion, particularly at low doses, as you can see here, right? So low doses together with diuretics will inhibit tubular secretion, and high doses, you can see it together with probenecid, it inhibit tubular reabsorption, right? So at low doses, it inhibits tubular secretion. The next group is glucocorticoids. You can give them orally, intra-articularly. You are actually injecting into the joint cavity, into the synovial cavity, or parenteral, as in injections. The next drug is colchicine, right? So this is the first and old drug. It was used by Hippocrates himself, right? So this drug binds and stabilizes tubulin to inhibit microtubule polymerization, impairing neutrophil chemotaxis and degranulation. Colchicine has acute and prophylactic value. It can cause gastrointestinal tract and neuromyopathic side effects. And it can also cause myelosuppression and nephrotoxicity. Thank you so much. I hope you enjoyed this video, and if you did, please make sure you give it a thumbs up, and don't forget to leave a comment in the comment section. Most importantly, subscribe, guys. Until next time.